Thank you for this nice introduction. Thank you for coming. Thank you to the sponsors. Thank you to the organizers. So we spent, probably a couple of days last week with Lisa trying to figure out if I have any fun facts about myself. So what I thought was fun, she thought it was too personal. What she thought was fun, I thought it was boring. And I was listening to Dr. Grewal, and I realized that in my previous life, I was an ENT, very previous life. And one of my jobs was actually to teach singers and actors how to sing. So we'll reconnect later on this topic. So this is more fun than silent cruises. Okay, so we'll be talking about, where is this thing? We'll be talking about the easiest topic I was given, right? PRRT for NETs. It all sounds Greek. And guess why? Because it is Greek. It is Greek. So essentially, PRRT stands for peptide receptor radionuclide therapy. So let's just do step by step. Therapy is a Greek word that means treatment. That's it. It's just a treatment. So radionuclide means there is an isotope that has radioactivity. So as simple as that. So peptide receptor. So receptors, think about it. Receptors, it's an antenna on the surface. Think about radio antenna or TV antenna. But it's very specialized. It could only pick up only one wavelength. That's it. So in our case, this is neuroendocrine tumors, and we are talking about somatostatin receptor type 2 usually. That's what we're using for PRRT. So, and the peptide is actually this wave that is specifically designed by God or nature, depending on what you believe in, or both. So to work with this antenna. So that's your peptide receptor radionuclide therapy. And we'll see some pictures. So, but essentially, this is a treatment that targets certain types of neuroendocrine tumors. For the sake of this discussion today, we will be talking about tumors, not neoplasms, which is a big umbrella that covers many types of neuroendocrine things, including carcinomas and tumors. Tumors are usually low-grade, less aggressive, and they do have time. Since they're not that's fast-growing, they usually have time to produce those receptors, those antennas that are sensitive to somatostatin analogs and somatostatin. So this treatment, as I said, binds to a specific receptor on the tumor cell and destroys the cells because the receptor and peptide complex, once they are attached to each other, the cell takes it in. So then the isotope is released and it damages DNA. That's the theory. So there are very many questions about it. Truth is, nobody still knows how exactly it works because there are so many other potential discoveries that we still have to make. But it works, but we're not quite sure how it works and why it works. But the concept is that it gets into the cells, destroys the DNA, and the cancer cell cannot replicate. So it's not a cure. So because PRRT was and still is, but it's probably 10, 20 years ago, it was a holy grail. Everybody wanted it because it was not available in the States. We used to send people to Europe. So because in Europe where it's originated, it was available for like last probably 25, 30 years. So it was holy grail, and people thought it was a cure. It's not. So it does not cure, but it could slow down the growth of the tumor. It could stop for a while in many patients. So, and overall, it does help to improve how long people live with this disease and the quality of life. Because, the current concept is we look at neuroendocrine tumors as chronic disease, and it gets more and more chronic, which is a good thing. So that's why quality of life is important, and how long life is equally important. So this somatostatin receptor, so this is, you probably heard about it, but somatostatin receptor, it's one of the most important things, at least currently when you talk about anything neuroendocrine. So it's present on the surface of most low-grade neuroendocrine tumors. And it's actually very important why we care about it, because we can use it for so many different purposes. So this is how we think it looks. So you see, this is a receptor. It's essentially a big molecule that consists of many amino acids. So it sticks the antenna on the surface. It's sitting there catching something that would match. So, and then the other end of the receptor, as you can see, it goes into, could we see? No, we don't have that. Oh, No, it doesn't work. So essentially, it goes inside the cell, and that's how it is. When it is internalized, everything that is attached to the antenna ends up inside the cell. So as I said, it's present on almost all neuroendocrine tumor cells. So you see that when people develop monoclonal antibody against this receptor, which means it's an antibody, it's part of the substance that the immune system makes, it is specifically designed to match. It's key and hole. Think about it, key and lock. So it's specifically designed to attach to this receptor and to nothing else. So when it was developed, then people thought, how could we use it? And we can use it to actually stain and see the stain. You see, this is the picture of neuroendocrine tumor after it was stained for somatostatin receptor analog. This is the test that we order quite frequently in real life, especially when tumor is removed, but people forgot, or for whatever other reason, did not do dot-to-dot PET scan. And you are wondering how you're going to follow up the patient if something comes up. Would dot-to-dot PET scan even make sense? Because some of the tumors, 3 to 5% of them, would not have this receptor, and you're doing PET scan, and it shows nothing, and you think, oh, gee, there is nothing. There might be something, but you don't know if the scan would have been positive or not. That's why we always, in situations like that, ask for the stain. So because if the primary tumor had the receptor present, means if something grows later in the body and we think it comes from this original tumor, it's more likely to have this receptor, and dot-to-dot PET scan would work. So this is how we use it to make the diagnosis, and that's how it looks under the microscope. As well, you can take a picture of it. That's how dot-to-dot PET scans were actually developed. It's the same receptor. It's the same receptor, and you have the peptide that attaches, the little wave that is specific for this antenna, for the cancer cell, and you attach to that little light. Think about the key chain, and little light on the key chain. So that's what it is. It depends what you attach to this little metal ring that is attached to your key, right? So in this case, we attach gallium-68, which is a radioactive isotope. Its radiation is not significant enough to cause any significant damage to control tumor, but you can pick it up on the scans. And that's how the imaging was developed. So you can picture the presence of the receptor. And this is critically important, as many of you know, in everyday clinic life, but when you take care of people with this type of disease. So let's see. So, and you see the examples of the how PET scan looks. So, and somatostatin analogs, many of you are familiar with sandostatin, LAL, and reatide. So that's how it works. It's an analog of the natural substance that the body makes. It's somatostatin. That's body makes it. That's what Dr. Oderisi, rest in peace, used to call the universal switch off in the body, works on very many switches in the body. So, and then people develop somatostatin analogs, which looks like a real thing. And when you inject it, it goes to the cell, finds the antenna, and attaches to it. And that's how it does. And we have 2 drugs right now that we are using actively. So it attaches, and what it does, it decreases the cell growth, it increases the rate at which the cancer cells die, and it decreases in those tumors that produce hormones, for example, those that are responsible for carcinoid syndrome. So secretion of hormones decreases. But it's not entirely related to PRRT, but I'm just telling you what somatostatin receptor means and its presence. So, and of course, it's a target for PRRT, for radionuclide therapy. So it's the same receptor, the same cell. So the same thing that has affinity to the receptor, but instead of nice and soft gallium-68 or copper-64 for that reason isotope, you attach a nuclear bomb to it. So lutetium-177. You can attach Y90, yttrium-90 as well. That's a different story. So they use it mostly in Europe for larger tumors, but essentially it depends what you attach to your key chain. So if you attach nuclear bomb, you're going to have an explosion, and hopefully the cancer cell will die. So and these are graphs that I will show briefly because we'll talk about it in detail. That's from NET1 trial. So just to recap, you see the picture on the bottom. So essentially you have the key that matches the lock, the dark yellow color. You have the octreotide peptide, that's essentially the ring on your key. So, and then whatever you attach to this ring, in this case, lutetium-177 attached, and this is the treatment option. If you attach, let's say, gallium-68 much milder isotope, you don't have any damage, but you can image it because you can pick it up on the scans. So lock and key system, it targets somatostatin receptors. So, and response rates, objective response rate, which means tumor either disappears or shrinks. So it's 15 to 35% depending on what data you look. It does improve quality of life when it works. It does make people live longer. So, and it does make tumors to stop growing for a while when it works. So majority, the key is that, that's lutetium-177, which just attached, you see the killer. So that's how it works. This is a beautiful picture from Dr. Havdanerson, the Trojan horse. You see on the right, a little bit complex, but the substance is attached to the receptor, then the cancer cell sucks it in, then there is the degradation of everything but the isotope, so body takes care of it, and isotope releases radiation, and it causes the damage to DNA. So there is only one drug approved in the United States right now. This is Lutathera, as many of you are familiar. So the formal indication is for treatment of somatostatin receptor positive, means you have to have the scan or you have to have the stain. You have to prove the tumor has receptor, otherwise it will not work. So gastroenteropancreatic neuroendocrine tumors, which is essentially small bowel, large bowel, and pancreas. People with pancreatic neuroendocrine tumors were not included in the clinical trial that led to the approval, but subsequently FDA just included it. It's a long story, we can talk about it offline. So, and now the latest addition to the indications, not just adults, it could be children, 12 years and older. And this is on the right, that's how it actually looks when it comes to the clinic. It's a little vial, and it comes in this radiation protective case, 3 minutes left. Perfect. So how it's given, it's just simple IV infusion. There is nothing particular about it. Initially, when the clinical trial was developed, it was just given with gravity, means you just hang it and it goes. Later, I should proudly say the Banner and Anderson Cancer Center developed the protocol when we were doing the expanded access part of the trial for our patients. We developed the protocol to use the pump. Now, lots of people use the pump. So it's usually 4 treatments. It's every 2 months. So it's over 8 months. It's IV infusion. The whole thing takes probably 5 to 6 hours. So because you need to give premedication for nausea, then you start amino acids to protect your kidneys. So amino acids keep going for 4 hours, and usually 30 minutes after you start amino acids, you give the actual infusion of Lutathera, which takes just 30 minutes. And that's it. And after that, you finish amino acids. So usually we try to use two lines of access because you don't want to mix it in the same IV line. So who is usually eligible? So it's people with neuroendocrine tumors of the pancreas, stomach, small bowel, large bowel, and rectum, if you stick to the guidelines and to the package insert. So usually those people are not candidates for surgery because, as I keep telling my patients, and surgeons love me, I usually tell patients there is nothing better than the knife. So if you can remove it, you are very much done in many cases. But sometimes, as you know, cancer cannot be removed. So for those patients, PRRT is considered. So tumors must have somatostatin receptor on the surface. So tumors have not responded to prior treatments. That's how it was initially approved. Tumor was progressing after the initial first line of treatment. And for more aggressive neuroendocrine tumors with Ki-67, 10 to 55%, and large volume disease, NET-2 trial showed that you can use it as the first line. You can use it as the first line. So obviously, patients need to be in good shape, enough bone marrow resource, which means if bone marrow, which is blood factor, if it works okay, there is less chance of developing low blood counts, anemia, low white blood cells, and low platelets. So kidneys should be in good shape. That's what creatinine clearance means. So performance status, essentially, people need to be in good physical shape. They need to be able to walk into the office. That's what it means, because we all know that when people are not feeling well, when they sleep half of the waking hours or more, treatment is unlikely to help, but it could actually do some harm. And obviously, expected survival, I know it sounds horrible, but that's how you look at the situation. Expected survival should be more than 3 months, more than 3 months. So, and the trials that you probably heard about it many times, we will not be going into great detail, especially I have probably less than 1 minute left. So the NET1, it was the initial one that led to the approval of the drug in the United States. People with progressing grade 1 and grade 2 neuroendocrine tumors of midgut, which means pancreas was excluded. Usually it was mostly small bowel and large bowel. With Ki-67 index less than 20%, it was reasonably limited subset of people. So disease was controlled after they did the final analysis. Sorry, it's misspelled, means to say disease, not diseased. So disease was controlled longer with PRRT as compared to the control arm. Control arm was just high dose of somatostatin. So, you can see that median, which means half of the people had it longer, half of the people had it less. So it was 27.4 months versus 8 months. So people treated with PRRT obviously had better control of the disease and longer control of the disease. And significant toxicities were in 41% of people treated with radionuclide therapy versus 33% of people treated with high-dose somatostatin analog. And the NET2 one, the latest one that was published, so it was a little bit different group of people. It was first-line treatment, people with newly diagnosed high-grade 2 or 3 neuroendocrine tumors, so it's 10 to 55%. I know it sounds confusing, high grade, grade 2, but as you know, grade 2 goes, I'm out of time, yeah. Grade 2 goes from 3 to 20, and obviously when you have Ki-67 of 4%, it's very different disease compared to Ki-67 of 18%. So it's high grade, grade 2, so 10% Ki-67 and higher. And the results show that people who were treated with PRRT and octreotide injections combined that had longer disease control, 23 months versus 8.5 months. So, and this is first-line treatment. This is actually a very significant result. And toxicities were obviously more present in the treatment arm, so 16% versus 4%. So common side effects that people have, it's nausea, vomiting, abdominal pain, but usually not everybody has it. The actual percentage numbers are not that high. So diarrhea, a low lymphocyte count, platelets could go down, and the total white blood cell count could go down. So serious adverse reactions, you see most of them have chance of happening less than 2%, but if it happens, it's real. The biggest concern, it used to be kidneys, so not anymore because infusion of amino acids very much protects kidneys quite well, but it's now issues related to the bone marrow, long-term toxicity, myelodysplastic syndrome, which is a form of bone marrow cancer, so issues related to leukemia, et cetera. This is one of the biggest concerns when you think about long-term effects and whom to treat. Obviously, when you treat someone in early 40s and there is, 50 more years to live and there is 2% chance of a bone marrow problem, it's something significant and it has to be considered. So what's new? I know Dr. Chauhan will be talking a lot later today about what's coming in PRRT and clinical trials. So the latest and greatest, it's alphas. You probably heard about it because lutetium-177, this is beta emitter. It emits beta particles. So and it was good and it works as you just saw, but obviously science never stops. So next step is alpha particles, and there are clinical trials in that regard. So essentially the main difference with, between alpha and beta, alphas travel much shorter distance. They cannot go far, which is probably safer, no damage to the neighboring organs, and from the radiation safety protocols, it's much easier. And it delivers much higher dose of energy, and it kills tumors more effectively. And if you think about how beta particles affect DNA, you know DNA is two strands. So betas usually destroy only one, and it still cannot work. Alphas are so strong, they usually destroy two. So it's better tumor kill. So potentially it could be better for certain tumors, especially for those that are resistant for beta therapy. That's why one of the first trials that was started, it was retreatment. People who were treated with lutetium and then disease reoccurred, and the question was, do we retreat with the same lutetium or should we do something different? And this is something different. And as well, we hope that use of alphas will decrease the chance of bone marrow and kidney damage. But it comes with its own, as you will hear from Dr. Chauhan, it comes with its own set of unusual side effects. So, but this is probably the future. And with that, thank you.